A very good evening, everyone. I'm Dr. Komal, Chairperson, Foxy Medical Disorders in Pregnancy Committee. Today brings to you this webinar with amongst this Association of Maharashtra of Next Society on RPL, Isommunisation in Pregnancy and Minimal Access Surgery, along with Baramati, Malegaon, Nanded, Nasik, and Devli Sangvi Society. And at the outset, I would like to thank all the President and Secretary participating society and also give my regards to Dr. Alpesh Gandhi, President Foxy, Dr. Nandita Palchetkar, President MOX, Dr. Atul Ganata, Vice President in charge for my committee, Dr. Jaideep Tang, Secretary General Foxy, Dr. Arun Nayak, Secretary MOX, and all the esteemed panelists and chairpersons who have joined for today's program. I also give regards to Dr. Rajendra Desi, Vice President Foxy, who was our chief guest and has been held up because of personal reasons. But we have with us our guest honor, Dr. Kiran Kotakoti and Dr. Arun Nayak. And to begin with today's webinar, we have with us moderator Dr. Niranjan Chavan. He is the Vice President of Mumbai Obstetrics and Gynec Society, professor in the busiest medical college of the heart of Mumbai, that is the Sion Hospital, and he will be moderating today's webinar. He's also been a course coordinator for 11 batches of MUHS certificate course of basic and advanced minimally access surgery at Sion Hospital, and also has course coordinated 3 batches of advanced minimally access gynec surgery at Sion Hospital, and it is an ongoing course which is happening every year. So without wasting any time, what is Dr. Niranjan Chavan, who would formally welcome and introduce our guest of honors, who would inaugurate today's webinar, and the scientific agenda will flow. Thank you very much, everybody, and over to you, Dr. Niranjan Chavan.
Thank you, Dr. Komal Chavan. It's a pleasure to have today and to conduct this webinar on 25th of August 2020 in partnership with Bharat Serums and Science Integra as the academic partner. This is in the first time of our history and in India that we have reached so many regional associations, and one of them is All Maharashtra Obstetrics and Gynecological Society, and we are very proud of being associated today with none other than Dr. Nandita Palchetkar, who is at the helm of affairs as the president of MOX, and Dr. Arun Nayak, professor at Sion Hospital, presently the secretary of MOX. And it's our proud privilege to introduce them as the guest of honor. I would like you to welcome now Dr. Arun Nayak. He is the professor at Sion Hospital, and we all know that his field of interest is urogynecology and endoscopic surgery. We also know how he conducted his presidential year in Mumbai Obstetric Gynec Society in 2015, and he has a lot of awards to his credit. To name of them is the Foxy Korean Award. He has also taken training in Korea as a visiting clinical fellowship. And I want to tell you, his passion is SUI, and he has conducted many workshops. And you have seen him with us doing those SUI surgeries and endoscopic surgeries. He is also the joint organizing secretary of the AICUG 2013. He has got more than 40 publications to his credit in national and international journal. And the most important thing is that he is heading the Journal of Obstetrics and Gynecology of India as a joint assistant editor. Welcome, Dr. Arun Nayak. I request you to inaugurate this webinar of Foxy, MDIP, along with MOX. And please inaugurate and also say a few words. Thank you.
Thanks, Niranjan, for that kind introduction, kind words for me. And it's always a pleasure working at Sion. Niranjan is my colleague, and as a head of department, I always look forward to Niranjan in helping me in administrative and academic and clinical work. I think Niranjan, Kiran is also with us. It will be nice if we introduce Kiran also. Kiran is uh, uh, he is the second vice president of AMOX, and with me,
Yes,
Kiran also joins
yes,
me.
yes,
We can together start the session
yes,
and we
yes,
can
yes,
inaugurate this webinar.
yes. So thank you, Arun. You are always gracious and you are always kind. And of course, these are your pearls of wisdom which you have given to me. And I'm looking forward to your expert opinions in this webinar. Thank you so much for being there. And now we have Dr. Kiran Kortakoti. His surname is very complex, but he's a very simple man. And I know him for so many years, more than 2 decades. And presently, he is the second vice president of AMOGS. And I remember he taking over and working for the MTP committee as a chairperson in Foxy and in AMOGS. He has got numerous awards. His designation, awards, and publication are there. I welcome you and please guide. And I want you to tell something about AMOX too, so that the viewers can understand what is all Maharashtra Obstetrics and Gynecological Society about. Thank you.
Yeah. Thank you so much. Thank you so much, Niranjan, for those kind words. Whenever I see you talking, Niranjan, I guess probably in the current scenario of Foxy, you must have taken the highest numbers of webinars that I have attended, or you must have projected. Fantastic work, fantastic with you, with Komal. I think you are doing a very great job as far as Foxy is concerned, and of course, you are our own Amox people. So, thank you so much for that introduction. And well, to brief everyone about Amox, Amox, as all of you know, stands for the Association of Maharashtra State OBGY Societies. It was founded by late Dr. R.D. Pandit, and currently Dr. Nandita Palshetkar is at the helm of the affairs of AMOX. She is the president of AMOX. We have about 45 societies affiliated to us. There are about 7 zonal coordinators, 20 chairpersons, and a national coordinator also, and the state coordinators. So Sunita Tanwalkar is the state coordinator with Rishikesh Pai. And we have the Young Amounts Brigade also with Rohan Palshetkar now being groomed in. And so overall, we are doing a lot of activities with people like Niranjan, Komal, and everyone. So we look forward for this particular webinar, and we have a great set of panelists and academicians for this webinar. The academically endowed Dr. Sudekha Taide, and of course, you'll be moderating the next panel. So I guess with this few brief introduction, I would request Arun also to say a few words. Arun,
Yeah.
regarding amounts?
Uh,
Yeah.
Yes, sir.
yes. You already mentioned that it was founded by Dr. R.D. Pandit,
Yeah.
and the founder secretary was Dr. C.B. Purandare. And uh, we are doing in Maharashtra, we are doing a lot of, because being a regional organization, we have different issues. Our problems are different compared to the national organization. And we see to it that we try to reach even the remotest places in Maharashtra and try to find out what difficulties they are facing, especially in this era of corona infection. AMOX has distributed to the frontline workers, we have distributed PPE kits, we have distributed to the societies as well as to the medical colleges and the district hospitals in various places so that the frontline workers are taken care. And we are still continuing with our efforts so that we can reach out to our colleagues and anybody, any society, they can approach us in case there is any need for PPE kits or other protective gears. So thank you, Kiran. And I think we can go ahead with our webinar today.
Yes.
Thank you, Dr. Arun. I would like to mention here special reference to Sion Hospital, where Dr. Arun Naik is the head of the department. And it is a notable feature that, in spite of not being a COVID hospital, it is a non-designated COVID hospital. We have delivered, I think, more than 300 COVID patients, and also Dr. Arun Naik himself is the first author which has got the publication done in the Journal of Obstetrics and Gynecology of India, which is the first paper being, under the editorship of Dr. Khadilkar, madam. It was published, and I would like to thank Dr. Arun Naik for those efforts and the whole team of Sion Hospital. You have taken Sion Hospital to the road map of the world. So we are very proud of you. Thank you, Dr. Kiran and Dr. Arun. With this, I would like now to invite our chairpersons and who are also the session experts, Dr. Varsha Lade and Dr. Dilip Bambre sir. Dr. Varsha Lade, as you know, she is a part of the Nasik Obstetric and Gynecological Society. She has contributed more than 22 years of her life. She's the director of Prayag Hospital, Nasik, a gynecological laparoscopic surgeon, interest in high-risk pregnancies, and Sri Shakti awardee. Dr. Varsha Lade is a very good orator, and she also, we see her in many Foxy and AMOX conferences. Welcome, madam.
Yeah.
Thank you,
Good
Dr.
evening,
Varsha.
everyone. Thank you. Thank you for the kind words, Dr.
Yes,
Niranjan,
yes,
Dr.
yes.
Komal. Thank you for making part of this webinar. And may I have the privilege of introducing Dr. Surekha Taide. Can I have her slide, please?
Yes, before we go to Dr. Surekha Taide, I would like to introduce our next chairperson, and that is none other than Dr. Dilip Bambre, sir. He is a big legend in Malegaon. He's always an inspiration to the young gynecologist. I've been knowing him since last 20 years. He was a lecturer in Aurangabad GMC for 2 years, and as his own practice, he has taken training long time back in 1970s when we were kids. And I'm impressed that he has taken even diploma in laparoscopic surgery. He is the only successful endoscopic surgeon in that area, practicing for more than 35 to 40 years. And welcome, sir, that you are the founder president of the Malegaon Obstetric Gynec Society. I want you to say a few words. Please unmute your mic, sir.
Thank
Yes,
you,
sir.
Dr. Niranjan, Dr. Kumal, and Dr. Varsha. It's nice being with you all today, and I'm very eager to share your experiences, all of your experiences, so that I can learn a bit more. Thank you.
Thank you. So I open the session one. The mic is yours, Dr. Varsha and Dilip sir, to introduce our guest speaker, Dr. Surekha Taide. Please carry on. Thank you.
Yeah. Yeah. So our guest of honor is Professor Surekha Taide. She is a member of IAEC Committee Foxy, member of Family Welfare Committee Foxy. She's an ex-member of Study of Female Breast Committee Foxy. So she is involved in multiple committees of Foxy. And she was a past president of Sevagram Vardha Vijaya Society, as well as past president of the same society. She's a co-leader of Maternal Near Miss Project of the Government of India. She's one of the member of Government of India for all the committees. She's a co-leader of Maternal Death Review Project of Government of India. She has contributed developing content as faculty of ICOG online contraception courses. She was organizing secretary of SONA CME 2010. She's an expert committee member and national guideline of obstetric for SDU and ICU, and expert committee member of national guidelines for member of near miss and critical care obstetric. I'm very proud to have Dr. Surekha because she belongs to a public health person, and I look forward for her to be to have great many more achievements. I welcome this beautiful and vibrant lady, Professor Surekha Taide. Over to you, Dr. Surekha.
Good evening, everyone. Please allow me to share the screen. Thank you so much for those kind words, Dr. Varsha. And first of all, my greetings and my pranam to all the stalwarts of Foxy who are here, and Dr. Arun Naik and Dr. Kirtikoti from AMOX. My gratitude to Dr. Niranjan Chauhan for inviting me here today as the speaker for a very important academic activity, and also my gratitude to Dr. Komal Chauhan, who is the chairperson of the Medical Disorders in Pregnancy Committee of Foxy. So it is my proud privilege to be here and to share the knowledge and interaction with this August gathering. So Corona the pandemic is a very challenging times, but one of the very good opportunities which Corona has given us is to be with each other on this online platform and share knowledge and try to uplift our whatever existing knowledge is. So today I'm going to talk on a very pertinent topic, which is managing rhesus. So I hope the screen is visible to you. So
Yes.
this is my topic for today, which is management of rhesus negative pregnancy. I bring greetings from my college, which is Jawaharlal Nehru Medical College, Datta Meghe Institute of Medical Sciences, Wardha. And yes, presently we are being faced by this virus as rapidly, and we are aghast. However, let me tell you that though we are challenged with this virus, obstetrics sometimes does that to us too. Complications come out of the blue and consume us. However, there are predictors. And in the present case of Rh negative pregnancy, not only there are predictors, but there are various algorithms. If we follow correctly, then we could give a good outcome. So this is one of the conditions in obstetrics where a good algorithm and preventive measures have already been set in, and that is how we are able to give good outcome to our patients. So I hope every one of you recognize, and the audience is able to recognize these images. The first image is of hydrops fetalis, where you are seeing an abdominal swelling and swollen liver and edema all over of the body. The second image you are seeing is wherein there is jaundice, deep jaundice in a neonate and connectus. And third image you are seeing is of congenital anemia and of the newborn. So these all are associated with the present disorder, which is rhesus negative pregnancy and isommunisation because of this pregnancy. Hydrops fetalis is one of the most serious of the condition related with it. Because of isommunisation and excessive hemolysis, severe anemia, metabolic acidosis, there is hyperplasia of the placental tissue leading to fetal anoxemia and generalized edema, which we call as the hydrops fetalis, and leading to fetal death. So this is one of the conditions which is associated with Rh negative pregnancy. I'm going to outline my presentation with this agenda in mind, and let me continue with my talk with the epidemiology. Now, if we look at the epidemiology, globally, Spain has the highest incidence of Rh negativity to the count of 30 to 35%, which is very, very high. Otherwise, whites and Africans have between 8 to 15%. But if you look at Asians, the incidence is around 2%, which is considered less as compared to the white population. If you look at Nigerian studies, some of the studies have quoted around an incidence of 4 to 5%. So in India, we are having little less incidence, but because of the various challenges of communicating with rural patients and instituting preventive measures, we may see certain cases which are having poorer outcome as compared to the white population and other European population. If we look at the pathophysiology of the condition, we remember from our residency days that there are two commonest types of blood groups which are available. One is the ABO system and another is the rhesus system. ABO system we know very well. In the rhesus system, we understand that there is no D antigen. The letter represents absence of the D antigen, and the D antigen is considered to be the most immunogenic of the various antigen. It is also called as the Rh factor or the rhesus factor. If we look at the pathophysiology of the condition, we have a couple where the Rh negative mother is there who doesn't have any copies of the D antigen, whereas if the father is positive and if the father is heterozygous and has only one copy of the D antigen, then half of the children will be Rh positive and the other half will be Rh negative. Whereas on the other hand, if we have a couple where the mother is Rh negative and the father is homozygous with two copies of the Rh D antigen, then all the children will be Rh positive, and that is where we consider that isoamminization will be possible in this case. Now, let us look into the feto-maternal hemorrhage and Rh incompatibility. Amount of fetal blood which is necessary to bring about the isoimmunization varies, but as little as 0.1 ml of the Rh cells also can lead to isoimmunization. There are various studies, however, which quote some non-responders. What do you mean by non-responders is 30% of the people who are challenged with large volumes of Rh positive blood also will not have this isoimmunization. So let us know why some of the persons are responders even with small amount of Rh positive cell, and some do not respond. So this alloimmunization occurs by two mechanisms. One of the mechanism is after receiving incompatible blood transfusion. Another mechanism could be a feto-maternal hemorrhage between mother and an incompatible fetus. Now let us look at where and how this feto-maternal hemorrhage can occur. Usually it occurs during delivery, which is 90%. Sometimes it can also occur in the antenatal period, which is 10%. Notwithstanding fetal RBCs, they have been detected in the maternal blood in all 3 trimesters. So 7% in the first trimester, 16% in the second, and 29% in the third trimester. The initial maternal response to the Rh sensitization is low, and these antibodies are confined only to the maternal circulation, and they are unable to cross the placental barrier. Within 6 weeks to 6 months, the antibodies are formed, and these are able to cross the placenta, and then they are able to destroy the fetal Rh positive cell. Therefore, the firstborn infant with the Rh positive blood type is not affected. Why? Because the short period of exposure to the fetal RBCs is insufficient to produce a large number of antibodies. So the first pregnancy is not actually affected. However, the later pregnancies, if you have not given the preventive dose of, then the later pregnancies may get affected very badly, and you may get a poor outcome if you are not alert. So what happens in this hemolytic disease of the newborn is the maternal antibodies, they enter the fetal circulation through the placenta and they destroy the fetal RBCs, causing fetal anemia. The hematocrit of the fetus, when it is below 30%, we consider it as the anemic fetus. The heme is formed as converted into bilirubin and give rise to fetal hyperbilirubinemia. Later on, the neonate may land into kernicterus. Because this bilirubin is neurotoxic, it is effectively cleared by placenta and metabolized by the mother. However, large amount may not be able to be metabolized. Extramedullary erythropoiesis is stimulated, immature erythroblasts are produced. What happens is when the cell destruction exceeds the production, the severe anemia sets in. More demand is there for extramedullary sites to produce more amount of red blood cells, leading to hepatosplenomegaly in the fetus. And the fetus undergoes heart failure, giving rise to ascites, edema, and pericardial effusion, leading to erythroblastosis fetalis, which is considered as a fatal condition. And also, hydros fetalis will occur if the hematocrit falls below 15%. Males are more affected here. Like in many conditions, we have seen that the male is having a biogenic potential to undergo these sort of issues during pregnancy. 13.1% to 1, 13.1 to 1 is the ratio between the male and female fetus to getting affected by this condition. So if you look at this image, a couple where there is a Rh negative mother and Rh positive father, there is Rh isoimmunization, but which is not a problem in the first pregnancy. However, these Rh positive antigens stimulate the formation of Rh antibodies, enter the maternal circulation, In the subsequent pregnancy, if there is again a Rh positive baby, these antibodies can reach the fetus via the placenta and destroy the Rh positive RBCs, leading to development of fetal anemia and other consequences which I have already talked about. So, what is the risk and how the risk is decided? The risk and severity increases with each subsequent pregnancy. So, if you have hemolytic anemia in this, then later on in the later pregnancies, you may have hydrops. So, if you do not give any prophylaxis, this risk is 16% after 2 deliveries, out of which 1.5 to 2% will occur in the antepartum period, 7% within 6 months of delivery, and 7% manifest early in the second pregnancy. So in the second pregnancy, we find that early, even before the 20 weeks of pregnancy, the baby will get affected. If you give a proper prophylaxis, the risk will drop to 0.1%. So here you see very well the role of preventive medicine and how the risk is dropping from 16% to 0.1%. Now, this risk depends on 3 main factors. One is the volume of the hemorrhage, how much hemorrhage has occurred, how the immune response is there from the maternal side, and if there is a concurrent presence of ABO incompatibility, the risk will drop. So all these factors will play a role in the type of response and the type of disorder which is occurring. Now let us go into the management, which we are as a clinician most concerned with. Now, when we are managing this patient, we have to look at the potentially sensitizing events which has occurred in this patient. Is there any evidence of abortion or invasive procedure like amniocentesis or chorion villus sampling? Was there any trauma, abruption, intrauterine fetal demise? Is this gestation a multiple gestation? Was MRP done in the previous pregnancy? Is it an ectopic pregnancy or a cesarean delivery? So you have to look at the sensitizing event and document it. What was the event which led to the isoimmunization? Other aspects of the history also have to be explored, like whether the patient had any prior blood transfusion, what is the Rh typing of the patient as well as the spouse. You have to also look into the spouse, whether the spouse is homozygous or heterozygous. All the previous pregnancies, their outcomes, their interventions, we have to go into the details of what happened during those pregnancies, whether there is a history of hydrops. If so, the chances of recurrence are more than 90%. And of course, we have to ask about previous administration of the Rh immunoglobulin. So we need to ask, and we teach our residents to ask whether any costly injection was given in the postpartum period within 7 to 2 hours, and that is how our rural patients are able to communicate with us, yes, that immunoglobulin was given or not. Whether there was any injury to the mother during pregnancy, any presence of vaginal bleeding to rule out placental abruption, and prior invasive procedures. This all history has to be nicely taken and documented in your case. Now again, when we look at the antenatal management of the patient, the objective is to prevent the Rh alloimmunization in an Rh negative unsensitized woman. If there is a sensitization, then our objective is early detection and institution of the treatment of fetal anemia. So detect the fetal anemia early and if possible, treat it in utero itself. Sensitization, of course, in the antenatal period is determined by the indirect Coombs test, which we called as the antibody screen test. And I'll tell you in my further slides when and how frequently we should repeat the indirect Coombs test. Now again, from this algorithm, we are able to understand that if there is a mother who is Rh negative and a father who is Rh positive, we do this indirect Coombs test at 20 weeks, at 24 weeks and 28 weeks of gestation. If we find that the screen is negative, then we will administer the immunoglobulin 300 microgram at 28 weeks of gestation. This we need to really remember and train our people, our early career individual, our residents have to be taught that antenatally also the immunoglobulin has to be administered at 28 weeks of gestation. At delivery, we will find out the RH status of the baby. If the baby is negative, no further treatment is required. However, if the baby is positive, we are going to again administer the second dose of 300 microgram of NTD within 72 hours of delivery. This is about a non-sensitized woman, that is a negative screen woman. Now, if the antibody screen is positive, how do we go about? How to manage this sensitized pregnancy? Now it is recommended to do a amniocentesis for estimation of fetal bilirubin levels with at an optical density of 450 nanometers. This was the older version where we used to be doing amniocentesis, and presently this has been replaced by some non-invasive methods which I will be talking about. And depending on the amniocentesis and what is the value of the bilirubin levels at this particular optical density, then we will decide what is the fetal condition and whether you would like to go ahead with the percutaneous umbilical blood sampling, whether you would like to do an ultrasound or Doppler. We will further, I will be talking about it. Now, if we have this sensitized woman and this baby is being delivered, what precautions we should take during delivery? Ensure that we have a neonatologist present for the delivery. Don't give any oxytocics. Specifically, if you're talking of oxytocics, I would like to mention that we do not give methergin in this patient, which was recommended earlier. Presently we are giving oxytocin at not at the delivery of anterior shoulder, but within 1 minute of delivery. So we are recommending that we are not going to give methergin. If you want to do any interventions like manual removal of the placenta, be gentle so that there is no feto-maternal bleed. If you are giving any blood transfusion, then you should give only Rh negative blood. And of course, if early clamping of the umbilical cord is indicated, leave a long length of the cord around 15 to 20 centimeter so that if any intervention is required for the baby, then we have a good amount of length of cord to do those interventions. Again, involving the neonatologist is very important so that we can send a cord blood samples for ABO and Rh typing. Doing the direct Coombs test is very important in the neonate. Hemoglobin, bilirubin levels and a peripheral smear to find out if there is ongoing hemolysis, what is the hematocrit value, is there anemia in this newborn, and of course if the fetus is Rh negative, no further intervention is required. However, if the fetus is Rh positive, you have to determine what amount of immunoglobulin you are going to administer to this mother. What amount and what dose is required will depend on the 4-step laboratory procedure which I am going to presently enumerate to you. Now, what is these 4 steps lab procedure? First test you are going to do is the Rosette fetal RBC screen to find out if there is any feto-maternal hemorrhage. If this screen is positive, then you will do the Klehor-Betke test to quantify the amount of RBCs which has entered into the maternal circulation. You estimate the volume of the feto-maternal hemorrhage, calculate the dose of the immunoglobulin to be given and give it within 72 hours. So what we were taught during our residency was give 300 microgram of this immunoglobulin. But sometimes if there is large amount of bleed, this 300 microgram may not be sufficient. So calculating this dose according to these 4 steps which I have enumerated is very, very important. This is how a Rosette test will look, and you can see on the positive side that there is the clumping seen, and very nicely you can see the positive Rosette test here. If this screen is positive, then we do the acid elution test, which is seen on the screen now. Very nicely the fetal RBCs have been, this is called as acid elution test, which will quantify the amount of the volume of the feto-maternal hemorrhage. Now, for sensitized women, we are going to manage in the following way. Again, if this woman has been sensitized in the previous pregnancy also, we need to take a history of any affected fetus. Was the previous fetus anemic? Was the previous fetus hydrops? Depending on that, you may institute the management in this pregnancy. If there is no such history of affection of the previous fetus, then you do the antibody titers by your indirect Coombs test, and depending on the titers, you determine whether the sensitization is there or not. So if the titers are high, then we consider that the mother is sensitized and we need to. So this is, I'm not going to go in too much details of the indirect test and the direct test, because that is not under our purview as a clinician. I will just talk about how you manage clinically the patient. So, management of a sensitized Rh negative woman who doesn't have a previous history, you do the ABO and Rh typing of the husband. If the husband is positive, obtain an antibiotic titer. If the husband is negative, you don't need to do anything. Okay, but if the husband is positive, do the antibody titer. If the antibody titer is below the critical level by 36 weeks, you don't need to do anything. You just monitor the patient regularly. However, do not allow the patient to go post-dated. Now, in case your antibody titer is beyond a particular critical level after 34 weeks of gestation, so that 34 weeks has already been crossed, you need to just deliver your patient immediately. If the titer is beyond the critical level before 34 weeks of gestation, then what all tests you need to do is a non-invasive test, which is peak systolic velocity of the middle cerebral artery. So you do a MCA Doppler and do the peak systolic velocity there and find out if it is high velocities are there. If high velocities are there, then maybe an amniocentesis for spectrophotometry may be needed. You may have to do an ultrasound examination of the fetus to find out if the fetus is affected by hydrops, and you may further be need to do a percutaneous umbilical cord blood sampling to find out the hematocrit of the baby, and if required, you may need to give a intrauterine transfusion to this fetus. Now, if there is, on the other hand, if there is a previous history of already affected fetus, then you know that there is already a sensitization. You have to directly go for chordocentesis, find out the hematocrit of the baby, and you may need to do directly amniocentesis spectrophotometry and take a decision of doing a surveillance of this patient starting from 18 weeks itself. You need to do a MCA Doppler for this patient. So this is how you go about the management. Now, if you want to do the fetal assessment by these invasive procedure, in this picture we can very nicely see amniocentesis is done to find out the bilirubin level and check it at the optical density of 450 nanometers, and this is how you can, under the ultrasound guidance, you can do even the chordocentesis and the hematocrit value of this baby. Management depending on MCA Doppler is also very nicely depicted in literature. MCA Doppler is now considered as the mainstay for the monitoring of the baby and deciding the further management. It is very accurate. Of course, it is non-invasive screening tool, and it is able to detect moderate to severe fetal anemia very well. Sensitivity is around 100%, and this use of MCA Doppler, I remember when I was a resident, we used to always talk about amniocentesis, but now within the next last 5 to 8 years or more, MCA Doppler has been used, and it has resulted in 80% reduction in the invasive testing. So we now no more recommend the amniocentesis or the Lilly's chart and all, but MCA Doppler is considered as the mainstay of the monitoring of this patient. It may not be done before 18 weeks of gestation, however, because the reticular endocrine system is too immature to hemolyze enough to cause significant anemia. It may not be a reliable predictor of severe anemia after 35 weeks. However, it is found to have a better predictability as compared to amniocentesis, and that's why we recommend that the middle cerebral Doppler should be done after 18 weeks of gestation. We all know that in anemia we are going to have rising peak systolic velocity. Here you can see in this second diagram, you are having peaking of the systolic velocities, and because of dilutional effect of the fetal anemia, you are going to get these kinds of Doppler, and that will tell us, prompt us what would be our next step. So MCA Doppler monitoring is very, very important. If the fetus is unaffected, you will have a normal MCA Doppler which can be repeated monthly, and then you may try to deliver the baby nearer term. This baby will be considered as low risk for an intrauterine fetal death. If the affection is moderate, then you will have an MCA Doppler which is showing a rise of 1.5 multiples of median. Now you need to repeat the Doppler every 1 to 2 weekly, and you try to take the baby towards 34 weeks of gestation, and then once the lung maturity is considered to be achieved, you may try to deliver the baby. If there is a severely affected fetus, then the MCA Doppler is more than 1.5 millions of multiples of median, and there may be an evidence of an ultrasound of frank fetal height drops, and here now the fetus needs help to attain lung maturity. You may need to give steroids. This baby is a high risk of intrauterine fetal death, and you have to take a decision of early termination of this pregnancy. That is how MCA Doppler will nicely tell you how to go for intervention, at what gestational age you need to terminate this pregnancy, and whether any intrauterine interventions are necessary or not. Now here is the spectrophotometry chart which we used to learn very well. This is the Lily's chart. On the first, which we are seeing zone 1, zone 2 and zone 3, which may not be considered accurate before 26 weeks of gestation. That's why we are having another chart which is called as the Queen Anne's chart. Which are having 4 zones. One zone is the Rh negative unaffected zone, then there is an indeterminate zone, Rh positive zone and IUD zone. So depending on the optical density, the bilirubin level at OD 450 nanometers, we chart on this on the chart and decide what could be the further management of the patient. However, we are not using these charts anymore. More amount of stress is given on the non-invasive MCA Doppler, where there is no availability of doing an intra-umbilical, fetal estimation of anemia. Maybe we can use these charts to decide when to terminate the pregnancy. So now, depending on the MCA Doppler velocimetry and the peak systolic velocity, if it is above 1.5 mom, then you go for the fetal blood sampling and consider an intrauterine transfusion for this baby. If no facilities are available, then you may go for amniocentesis and decide whether you want to terminate this baby and go for neonatal transmission. If it is less than 1.5, then you go for 1 to 2 weekly monitoring of the MCA PSV and again decide when to terminate. So this is how MCA has helped very nicely in determining not only the monitoring but also any interventions if they are required. So now, if intrauterine blood transfusion is needed for this patient, it is recommended if your baby is severely hemolytic, having anemia, and thus you are going to give the in utero transfusion to this baby. May be carried out between 18 to 35 weeks of gestation, and once the 34-35 weeks of gestation is reached, then you take the decision to terminate the pregnancy. This transfusion could be given intraperitoneal or intravascular. Basically, we want to use only Rh negative packed cell, and those packed cells should have an hematocrit value of at least 80%. and the amount to be transfused depends on the gestational age. So there is a algorithm here, gestational age minus 20 into 10, and usually we give transfusions when the gestational age is more than 20 weeks. So we start from 10 ml, and depending on the gestational age, we may give more amount of blood to the fetus. That is called as intrauterine transfusion. When we do an intrauterine transfusion, of course, we have to take help of the ultrasound, identify the vessel, which is the umbilical vein, and then we do the transfusion. Nowadays, this procedure is mostly done by fetal medicine experts, but wherein the fetal medicine experts are not available, we could do it in an institutional setup with the help of our radiologist friends. So now this patient who is sensitized will need a very good management of the neonate in the postpartum period also. If the baby is alive, you have to admit this baby in the intensive care, and herein the baby is going to need an urgent exchange blood transfusion if the baby is moderate to severely affected. If a mild affectation, then only phototherapy will help you out, but most of the time those babies who are severely affected need a exchange transfusion, and you may need a neonatologist, expert neonatologist to handle this baby. Now again, there are special fetal-maternal risk states. If there is an abortion, then up to 5% chances of sensitization is there, and that the recommended dose of the is 50 microgram. If in case of invasive fetal procedure, the sensitization is around 11%, and recommended dose is 300 microgram of immunoglobulin. If there is a risk of antepartum hemorrhage is there in the present pregnancy, then we give a dose of 300 microgram to be repeated every 12 weeks later. Again, if you have done an ECV in a breech presentation, if you have done an external cephalic version, then again you have to give a prophylactic dose of 300 microgram to this patient. You should remember here that in case of an abortion, only 50 microgram is recommended, but other condition we are recommending a 300 microgram of dose. Now, when we consider the delivery, the normal amount of fetal blood which enters the maternal circulation is less than 0.5. So we recommend to neutralize this amount 300 microgram. However, as I have earlier stated in my previous slides, that the management and the amount, the dose of the immunoglobulin is to be estimated with the 4-step lab test I have already talked about, and depending on that we need to decide if more dose of immunoglobulin is required. What is recommended is at least 20 microgram per ml of fetal RBCs we have to give as a neutralizing dose, so that the sensitization is not there in the next pregnancy, is not affected. Now let us see what are the recent advances when we are looking at the management. In the recent advances, non-invasive fetal RHD genotyping. We know that when we talk of the non-invasive genotyping, we are talking of the cell-free DNA which is available from the maternal circulation. So you just take a small amount of maternal blood, 4 to 5 ml, and you go for a cell-free testing, and you are able to find out the fetal RHD genotype, and then depending on that you can. So again, point of care tests, rapid tests are available to know the fetal RH status, and depending on that you could decide what could be the antenatal management of this patient. Again, point to be noted is that the only for abortions, only 50 microgram of the dose immunoglobulin is required. And of course, there is another concept of partial D and weak D antigens, which usually they test positive, but they also can form anti-RHD antibodies. So these are the recent advances which are coming up, and which we should bring into our training to our postgraduates and early career individuals, so that they, in their routine practice also, you can advise self-free DNA testing and finding out the fetal Rh status. And of course, when we come to some take-home points, we have to remember that early every woman of childbearing age should have her ABO and Rh tested. We recommend this practice to all our antenatal women. Not only Rh typing is important to for deciding whether the immunoglobulin has to be given, but also in case if there is any bleeding condition, like in the antenatal period or in the postpartum period, we should have an ABO Rh typing of every child woman done. Obtain the Rh typing of the husband, find out if the husband is homozygous or heterozygous, and ensure that the ICT is done at 20 weeks, 24 weeks, and 28 weeks of pregnancy. So a serial testing is very important to find out if there is any rising titer. And of course, a postpartum dose, which we recommend as 300 microgram, may not be always adequate. So find out what is the severity of the feto-maternal hemorrhage, and depending on that severity, we have to decide what dose has to be given. So these are certain take-home points which I want to stress upon. Now, what are certain problems in our setting? Why we are not able to achieve that zero negative outcomes in our patient? Why? Because the cost of the immunoglobulin is considered quite high for our poor women. It is around 2,500 to 3,000 rupees in our setup, which may not be affordable to our rural women. Lack of resources to adequately investigate and monitor the fetus in utero, that may be one of the challenges which we have to think solutions about. So many a times we find that there is low turnout for antenatal clinics and certain missed cases may be there. Presently, in the pandemic situation, we are finding that the antenatal visits are reduced so much, and our peripheral workers are not able to give those kind of home visits, and that may again lead to lot of missed cases. Poor documentation of the prior sensitizing events. The patient is not able to tell you what has happened, and that may again lead to your challenges. Many a times the patient loses her previous case histories, and we are not able to find out if there were any sensitizing events. So what are the recommendations and how do you face these challenges? What could be certain solutions to these challenges? Now, one of the advocacy is partnering of the government with certain NGOs so that the cost of the immunoglobulin can be reduced and it can be affordable to our rural patient. There we can think about certain insurance covers to our Rh negative women also. Here in our institute, we have a Suman project which ensures that in only 500 rupees, we are able to give free services, not only for vaginal deliveries, but also for cesarean section, and even blood transfusion if needed is given free of cost to our patient. So such kind of insurance cover, if we can devise for our patients, then we will be having more successful outcomes in these patients. Again, premarital counseling is important. If there is an Rh negative woman, then premarital counseling is very important. And again, of course, we see in European countries, there are peer groups for so many conditions. You know, testicular feminizing syndrome, you are going to have a peer group. You are having peer group for so many other, breast cancer patients. So you should create peer groups for Rh negative women also, so that they can share with each other what has happened, and this awareness can be created in our population so that we can reduce the adverse events. Finally, to conclude my presentation, yes, rhesus alloimmunization is a problem. Efforts are needed to mitigate the impact, and although its incidence is quite low, there could be in certain patients consequences like hemolytic disease of the newborn and hydrospitalis. So if we are alert, we can diagnose the condition. Great advances has been made. MCO Doppler has come, and intrauterine transfusions Our fetal medicine experts are there, which can help us out, and we can give a good outcome to our Rh negative women. Thank you so much. These are my references, and I hope I was lucid to give some messages to my audience. Thank you so much.
Thank you, Professor Surekha Taide. It was excellent presentation. Superbly cover recent advances also what is to be done, and basically the MCA PSV is to be done for each and every patient to know what is the degree of severity of anemia. I agree with you about the non-invasive techniques. Let us hope we should come up to there and reduce this isoimmunization problems. Thank you so much, and over to you, Dr. Niranjan, for the panel discussion.
Yeah, I would like to hear some comments from the other chairperson, Dr. Dilip Bhamre sir.
Bhamre sir?
Thank you. Hello, can you hear me?
Yes, sir.
Okay. First of all, let me thank you, Dr. Taide, very much for a very good presentation. And there were certain things that, though I was aware of, I was not very much rigorous about, like 20, 24 week and 28 week scat and illustrations. Thank you for reminding that to us. And
Thank you so much, sir, for your nice comments.
Thank you. Wonderful presentation, lovely slides, and the flow of the slides and your speech was so good. I want to tell you more than 800 members and users have logged in and are live to hear you. And we have questions from Dr. Meena, Dr. Sasikala, Dr. Sanjay. This is Bhavna Chauhan, and there are many more. And I would like to thank all of them. It's not only Maharashtra, but it's all from the nook and the corner of India that people have joined you. So I have few questions. I will take them, and then we will go to the panel.
Thank you.
Yeah. Should we give anti-D in the threatened abortion without pain and not recurrent bleeding?
So it is recommended that if there is threatened abortion also, that we should give, because only 50 microgram of immunoglobulin is advised, and we do not know if the fetal-maternal hemorrhage has occurred. So it is recommended that we should give the immunoglobulin.
Okay, thank you.
Are you able to hear me? Yes.
Yes. Is there any effect on child if both the parents are having O positive blood group? This is a very simple question. I'm sure.
RH isoimmunization is considered only if the mother is RH negative and the father is RH positive. So if they are both positive, then there is no. I have very nicely depicted that when the couple, if the mother is negative and the father is positive, only then the sensitization will be there, and whatever algorithm is only
absolutely. What is the time to give the anti-D in the antenatal cases? What is the time? When do you recommend?
At 28 weeks of gestation, it is recommended. 300 microgram of immunoglobulin is recommended in all women, whether they are sensitized or not sensitized. We are recommending that at 28 weeks of gestation, the antenatal dose has to be given.
Wonderful. There are many comments for you. Dr. Alpana Agarwal, Bareilly, wonderful lecture. Dr. Manjusha Satish Chaugule, Mumbai, excellent lecture. Dr. Sudesh Doshi, Pandarpur, good talk by Dr. Taide. Madam, you are very popular.
Thank you.
You are a very, very good teacher. Thank you so much. We will get back to you soon. One more comment from Dr. Uma Bansal from Thane. Excellent presentation, Dr. Taide. And people are watching you, and we will get back to you soon. Please be there. And I request Dr. Kiran Kurtukuti also to comment here, and then we can go ahead with the panel. Thank you so much.
That was really a fantastic talk. I mean, I wish I would have been your student, madam. Thank you so much. Thank you so much for enlightening us on this particular topic. Thank you so much. I guess Niranjan, we should get over with the next
Yes.
panel.
I know.
Thank you
And
so
we are going to be there 45 minutes for the RPL, and we are having members still joining. So I will start sharing the screen now. And I hope, where am I? I better find it. Oh my God. Okay. So please wait for some time, and I will get back to you. Inal. Minal, can you share the screen in the meantime? Just 1 minute, please. I had it downloaded yesterday. Thank you so much. And well, recurrent pregnancy loss and minimal access surgery panel discussion. Please go ahead, go on changing the slides. Thank you so much. I'm going to moderate. Well, we have our esteemed panelist, Dr. Arun Naik. We have already introduced Dr. Mangesh Narwadkar. He is the president of Nanded Society, past Eurogynac, chairperson of Foxy, a very hard worker. Dr. Shekhar Amle sir, welcome. Join us. You are the president of Nasik Obstetric and Gynec Society. I had met you at AICUG and I met you before also. Dr. Rajesh Kokre is the president of Baramati Society. Baramati is always in the news, and so is Dr. Rajesh Kokre. He is a very good endoscopist. He is a part of the Maharashtra chapter of IAG, and I welcome Dr. Rajesh Kokre.
Thank you, Niranjan.
Thank you. I love that picture of yours with the sadhu who is there. I don't recollect, but I think I met him in Lucknow. Thank you. And Dr. Mugdha Bamre from Malegaon. Yes. Dr. Mugdha Bamre, Evergreen, she is there. And Dr. Rohan Balchakar is on the way. We will get to him soon. We know him. He's already a part of AMOX, joint secretary, member of the managing committee of MOGS. And we will get back to him soon. So we start with the first case. Can we go ahead with the slides, please? I would like to quote here T.G. Thomas. He says, in 1908, I recall nothing which in times past has caused me more anxiety and doubt, or in regard to which I have found it more difficult to get any satisfactory rules from the books than the treatment of abortion. So such is the mystical challenges of RPL. And we go to the next slide. What are the common questions asked by the RPL patients? Nowadays we are in lockdown, but still we have patients coming up, and we can have the next slide. What are the patient questions? Why did it happen? Will it happen again? How it can be avoided? And all the time we are explaining could have been it avoided. So this is what we are going to answer. What is the incidence of RPL? We know it is 1 in 300. And I want the next slide, please. I can't tell you again and again the next slide. Keep on rolling. Please keep on rolling. Yes, so this is what we see. 70% of the human conceptions fail to achieve viability, and 30% of us are only live presently on the earth, living here for decades. So there are 70% who never were born ever, and they just got lost their lives. We are the lucky few. And this is what is the situation with us. Next. So what is the definition? We know 50% of them are chromosomal abnormalities. Next. The definition of RPL: 3 or more clinically recognized pregnancies, losses before 20 weeks of LMP. That is RPL, and it is primary and secondary. And we want to go to the next slide. Meenal, please go on. As you hear my words, please go on. So primary and secondary RPL is there. They are repetitive losses. Primary is those referred to couples that have never had a live birth. And secondary, as you know, repetitive losses have occurred. Next one, please. So we are going to dwell today on all these topics. You can see it's a big, giant one. The causes of RPL, its genetics, fetal anomalies, uterine anomalies, immunological causes, hereditary thrombophilia, trauma, endocrine, all immune and infection. So one by one, we will go through the journey, and I want you to join, and please send your questions again and again. TOG is the #1 platform which we are going to see. And this is the beautiful breakup you see here of the various factors. and endocrine factors constitute the highest, and immunological factors which can't be seen or which are very difficult to understand or there is unexplained, we don't know. So this is what we are going to see today. And I will start with the first question to Dr. Shekhar Amle, and I request him to please read the slides so that we can proceed ahead. It's all yours. In the meantime, I'll arrange my slides. Thank you.
Thank you, Niranjan sir. Thank you,
Yes.
Amox, and thank you, one and all. The first case is 24-year-old Mrs. MSJ, married since 5 years. 5 years. Obstetric history is first was vesicular mole. For that, DNA was done. Second was again misabortion at 7 weeks, early abortion. DNA was not done. Pills were taken. Third pregnancy, again a misabortion at 6 weeks. Remember, it is 6 weeks again. And fourth, 6 weeks, that is current pregnancy, 6 weeks, blighted ovum, and pills are given, and we are waiting for her. And menstrual history is a regular, nothing particular, no suggestion of Asherman, no oligomenorrhea. Medical history is nothing particular, no history of diabetes or hypothyroidism. Family history, nothing particular, no history of diabetes in our father, mother. Clinical findings are normal, hormonal profile is within normal limits, and APLA is negative. It is clearly a case of chromosomal defect. So we would like to investigate her. We'll do her karyotyping. I suppose the karyotyping has been done, not her parents. Husband, it is 46XY, that is absolutely normal. Wife is 46XX, translocation at 1122, Q24 and Q13. That is something abnormal. This is suggestive of balanced translocation. By fish also, balanced translocation between chromosome 11 and chromosome 12 involving breakpoints at 11q and 24, 22q and 13 respectively. So now the question arises that cytogenetic studies of this product of conceptors should always be done, or should we do in this case? Considering her history now, we have given her pills anytime she will bleed. At that time, whether we should go for cytogenetic studies, because clinically now it is showing that it is a clear case of chromosomal anomaly. But why do we need to do cytogenetic study? According to me, first is to confirm the diagnosis so that she will be assured that other anomalies are not there and it is because of the chromosomal abnormality. And secondly, to know whether knowing only chromosomal, it is a chromosomal anomaly is not important. What type of chromosomal abnormality is that is very important for prognosis and future and for the couple to take decision. Like whether it is a translocation disorder or whether it is a deletion disorder or whether it is a disconjunction disorder or whether it is an inversion disorder. Accordingly, the geneticists, they decide what type of disease is that and prognosis is there. So it is very important to do cytogenetic studies of this concept.
Minal, can you just stop sharing? I will share the slides now. So I think all of you can see this wonderfully explained by Dr. Shekhar. Dr. Shekhar, you can please continue your talk.
Okay, whenever we do this cytogenetic study, mind you, it is very important how to send that sample. That is very, very important. Most of the time, we take it in normal saline and we send it in that. But it should not be done. It should be washed with normal saline and then should be sent to the lab in their preserving media, what they have sent to you. Once this has been sent, what we see is mostly observe aneuploidy in that. So whenever we get aneuploidy, repeat chances of getting aneuploidy and the prognosis is better in such cases. So
What is
So,
regarding the genetic counseling after the miscarriages?
genetic counseling should be done by a geneticist because that tells you for two reasons. One is the cause, and the second thing is the prognosis. And the couple decides afterwards whether they can go for PGD or they can go for a surrogacy.
Yes, sir.
It's the important decision they can take.
Hello.
Hello.
Yeah, continue, please. Hello.
So these important decisions they can take
वो तो
after
किसी
genetic
ने डाल दिया
counseling.
थोड़ा जरा.
So it is very important to send these patients for genetic counseling.
Shekhar, suppose the patient has been given an oral pills for a termination. So how can you obtain a sample for a study?
Yeah, that is the thing. Pills have been given. That is not the. That's why I said we are given our pills and we are waiting for to abort. So that time we can call or when bleeding is there. One more thing is there. There are two techniques. One is band and one is microarray technique. With microarray, it's small sample also. It's sufficient, and it is now high time that we should shift to microarray
Okay, but
because she can anytime come with bleeding. If she aborts fully, then there is a question. So pill giving that is open for panel for what should be given, whether pill should be given or not. If you are planning for to obtain a product or concept a specimen, then I think we should do a DNC.
that's okay.
Shekhar, hello.
Hello.
Shekhar, this is Dilip Amre. Because
Yes, sir.
this time this is a blighted worm. What sample are you going to send?
I didn't get you, sir. It is a blighted home. Then
This is a
again,
blighted worm. So, what kind of sample in this instance will you send for karyotype?
I'm not
There is a
getting you,
blighted
sir.
worm.
What type?
There is a blighted worm. There is
Yes.
just nothing but vacuum. Only liquid and maybe some current if there is. So, what will you be sending for this thing examination?
Sir, whatever sample I am getting, I will be sending because I cannot be selective in that. I cannot predict what is what because it will be blighted home, bleeding, misabortion. That's why she has come to us. So whatever sample is coming, I will try to send it.
Okay, thank you.
Yes, sir. Please continue. Dr. Shekhar, you're doing good. We want to know about the balanced reciprocal and Robertsonian translocation and the other rarer things which you had talked about. So please go ahead. I will forward the
Yes.
slides. You can see this. Yes, sir. Please go ahead.
Translocation is translocation. Location is place. Trans means that it has been exchanged. So in translocation, there are two types. One is balance and one is unbalanced. What do I mean by balance? Because we are talking for all the people. I am also an average gynecologist. I am a gynecological endoscopist and not geneticist. So I will be talking in one line and simple thing. Balance translocation is in which there is no loss of genetic material. And unbalanced, there is a loss of genetic material when exchange is occurring. So in reciprocal translocation, there is no loss of genetic material when exchange is taking place. In a Robertsonian translocation, in that what happens is that when their exchange is occurring in between two chromosomes, usually it is seen with chromosome 13, in which the centromere at the apex. So when the centromere is at the apex and they are uniting at that place, there is a loss of short arm of the chromosome. Now there is a short arm is lost in this thing, but short arm doesn't contain any genetic matter. So the parents, they are usually phenotypically normal. That is the thing in them. And if they conceive in their offspring, you may find it is a unbalanced translocation. So it is very important if Robertsonian translocation is seen in products of conception, their parents should be, karyotyping should be done.
Yes, sir. Please continue.
That is things. Huh? And the second thing is after Robertson translocation we have discussed. The second thing is the second abnormality is a deletion or a non-disjunction we can take. Non-disjunction, that is disjoint during meiosis or mitosis. Suppose two chromosomes, they are coming together, they are meiosis occurring and they will divide into equally 2. But in this what happens, because of disjoining, one daughter, this thing chromosome, they get 3 and one gets 1. So it becomes trisomy or a monosomy. That is a non-disjunction disorder. The second one is deletion. In deletion, what happens? There is a loss of total fragment or total chromosome or a part of the chromosome. A very common disorder seen is this Cry-Du-Chat syndrome, in which a fifth chromosome is part of the fifth chromosome is absent, and in this, these are the babies which are mentally retarded. And in mentally retarded baby, in French, they call it the cry of the cat. Whenever baby is crying, it cries, sounds like a cat. This is a very characteristic or a typical example of Cry-Du syndrome and a deletion disorder of a chromosome. Then for this, as we have already discussed, that counseling is very, very important to know the cause why this has occurred. Because in your first slide you showed, Dr. Niranjan, patient is hammering you. It is hammering you that why it happened and what is my prognosis, whether it will recur or not. All these questions will be answered with the help of a genetic. So genetic counseling is very, very important. They will use pedigree chart of all the their parents, their ancestors and everything, and accordingly they will calculate the risk of recurrence. So it is very important for these patients. And again, one more thing, whether they need a PGD or not, whether they will totally will shift the thing, whether they will adopt the baby or they will go for option of a surrogacy, it is up to them. So we can give them a better life, better options by counseling.
Yes, very nice. Thank you, sir. So we go to the next
Thank
case.
you very much.
Thank you so much. Wonderfully explained. I think Dr. Rohan is going to join us. In the meantime, we will then go ahead with the next case. I think that should be fine. Just wait for some time. I will have to rearrange this. There are many questions which have come. We will take at the end of it. And I find here Dr. Shekhar's case. And I got more than 110 slides. So we will just finish them as early as possible. Please bear with me. We are in a technological era. So I'll just see where am I. I have to go to case number 3.
Dr. Bhamre was asking one question to Dr. Shekhar.
Yes, in the meantime,
What
yes,
part should be
please.
said for
Dr. Bhamre can join us
Yeah. What
and ask a question, or anybody
should
can
be said for
participate.
when you are sending the samples, what should be sent? What part should be sent? I think, Dr. Bhamre, when we are sending whatever we have received, everything we should try and then send, because we cannot just differentiate that this is a abnormal tissue or this is the normal tissue or this should not be sent. Whatever part, whatever conceptus is available, everything we should send. One question I wanted to ask Dr. Shekhar, should we put it after putting it into the media, when we are sending the sample, should we put it in a ice bag? Because
Yes, sir.
many times when we are
Correct, sir.
transporting, if the temperature is very hot temperature, the tissue may get damaged. So it's better that we
Yeah.
put some ice cubes, not
Yeah,
inside, but
transportation.
around the bottle, and then send, so that the tissues don't get destroyed.
Sorry for, thank you for rectifying the thing. It should be sent what the way Dr. Nayak has said.
Yeah, Shekhar.
Okay. So I think, Dr. Arun, we will start your case. I request you to please read. Professor Arun, can you see the slides? Can you see my slides? Hello, Arun?
Yeah.
Yeah, can you see the slides?
No, there is nothing seen.
Sorry. Okay. Okay, I will reshare it again.
It is seen. For us, it is seen.
Yeah.
Can
Okay.
you see my slides now?
Yes. Now I can.
Yes, please go ahead, sir.
Yeah, this is a case for 22-year-old female who presented with pain in lower abdomen and right side of the pelvis, especially during periods. Her periods were early and profuse with severe pain in lower abdomen, which goes to back. And also there is a feeling of excessive heaviness in uterine region. Patient has had 3 abortions between 3 and 6 months in pregnancy. So I think again this is a case of recurrent pregnancy loss. And the ultrasonography showed posterior wall fibroid of size 4 into 6 into 5 centimeters in dimension.
So how would you approach this, Dr. Arun?
Okay, I think this is again a case of recurrent pregnancy loss. The pregnancy losses is not in early pregnancy, but it's little late. That is mid-trimester losses between 3 and 6 months. But I'm sure, Niranjan, this is a fictitious case and not a real case, because
Yeah.
I don't think that a fibroid of a size of 5 centimeter and 6 centimeter size would be missed in the early pregnancy. And most of our women, they do come for early pregnancy checkup and then sonography. Nevertheless, since this is the second trimester losses, two things come to the mind. One is the anatomical factors which are responsible for mid-trimester losses, whether it is because of incompetent os or whether there is any uterine abnormality, whether a developmental abnormality or it could be something like a fibroid or a tumor in the uterine cavity, distorting the uterine cavity. Okay, so these two conditions we should keep in mind. Now, how to differentiate whether the mid-trimester losses are because of incompetent os? Obviously, the patients will have labor pains which are for very short duration. Most of the time, the abortion occurs in very short duration and they are painless. Suddenly, patient starts bleeding or leaking, and in no time, the abortus is thrown out. So that's how we can make out that probably there is an incompetent os. Also, the when the pattern of the abortions in incompetent os, it always keeps the duration of gestation keeps reducing, because the os which is incompetent, maybe the first abortion occurs at a, little advanced age. The second abortion occurs little earlier because the os has already become more incompetent, and that is how maybe we can think whether it is because of incompetent os. Now, since this patient is having a fibroid uterus, whether really this fibroid is responsible for abortions or no, that we'll have to find out. And if the fibroid is it is intending into the uterine cavity, then that could be the reason. That could be the fibroid which is responsible for recurrent pregnancy losses. Now, for this patient, if she had come with a second, the abortion and the sonography was showing a fibroid, presence of a fibroid, maybe this patient need not wait for to become pregnant for the third time and even lose that third pregnancy also. Maybe even after the second loss, we can think of doing some doing a myomectomy for this patient so that she can have a safe pregnancy subsequently. Now, what are the factors which will cause recurrent pregnancy losses when there is the presence of fibroid? Whether the just mere presence of fibroid is responsible or no, that we should first find out. Now, the fibroids which are present in the uterine cavity obviously can impair the pregnancy outcome, and patient can have losses. But even when the uterine cavity is distorted because of the fibroid, because of some submucous fibroid or intramural fibroids also which are indenting into the uterine cavity, can have adverse outcome as far as pregnancy goes. The third is when there is an intramural fibroid. If the fibroids are small size and they are intramural, they are unlikely to have any adverse effect on the pregnancy. But if the size of the fibroid is more than 4 to 5 centimeter, or if there are multiple fibroids and the cumulative size of the fibroid it becomes more than say 5 to 6 centimeter, then these are the fibroids which may have adverse effect on the pregnancy and should be treated. Now, how we are going to know what type of a management the patient has to undergo? Depending upon how much the fibroid is indenting on the uterine cavity. If it is a submucous fibroid, we can think of going for a hysteroscopic approach. But if the majority of the portion, there is a grading, grade 0, grade 1, grade 2, depending upon that, we can decide whether we should go for a hysteroscopic approach or a laparoscopic approach. Now, when fibroid is basically into the myometrium or it is indenting outside on the outer surface, a laparoscopic approach will be a safer one. And if it is more into the uterine cavity, we can go for a hysteroscopic approach. And once the myomectomy is done, I'm sure the pregnancy will be will go to term and patient will have a safe, healthy child. So this is the video which is showing a laparoscopic myomectomy. Now again there is a debate whether we should be making incision with the energy source or whether we should be using a cold scissor. Now the recommendation is that a cold scissor is better to use because the tissue will not get damaged with the energy sources. The scar which will be left on the uterine surface, it will have non-necrotic tissue and the healing will be better. Now, after the fibroid is enucleated, as seen here, we can remove the fibroid, enucleate it from the base of the uterus, and then we have to suture the area, we have to suture the uterine incision in preferably 2 layers, taking care that the whole cavity of the fibroid is completely obliterated. Now here the cavity is not having any bleeding, but that's because of the effect of the vasopressin, and we should completely obliterate this cavity so that there is no dead space left, so healing is better, and subsequently there will not be a risk of uterine rupture in subsequent pregnancy. Now the suturing can be either with the traditional sutures, conventional sutures, or we can use a barb sutures where we have to just keep pulling the thread in one direction and the thread gets tightened. That avoids the multiple suturings or putting multiple knots because of the barbs. But when we are using the barb suture, one has to be careful that as much as possible, the edge of the barb suture should be buried into the tissue. It shouldn't be remaining, long thread should not be remaining outside because a bowel loop may come and it may get attached to the barb suture and they can be bowel injury sometimes. So we should try and then bury barb suture ends. Okay, and at the end we can cover the scarred area with either interseed or surgical so that it prevents adhesion formations at the site of the myoma. So
wonderful, Arun. You have explained very nicely the procedure of myomectomy, and this was, as you said, I hope you can hear me. This
Yes.
was a case which was actually a RPL, and we tried all the best, gave her immunoglobulins, also gave her aspirin, low molecular weight, but we did a hysteroscopy before the, that fibroid which was there, and the hysteroscopy did not show any fibroid abutting into the uterine cavity or it was any, submucous fibroid. So ultimately we thought, let us give us a chance, and we did this myomectomy, and wonderfully you have explained the procedure and how to go about it. And I appreciate, and I want to tell you that after this procedure. We put her on immediately ovulation inducing agents, and within 4 months she got conceived, and she has a child now. So these are all miracles of things which happen. We are just a medium, and to go ahead and give this mothers, these children, and I would appreciate all of you to be there with me today. So thank you, Dr. Arun. We will come back to you. Wonderful presentation. Bye,
Thank
Dr. Arun. Now I call upon Dr. Rajesh Kokre from Baramati.
Hello.
Yes, sir. Please go ahead and read your case, and we are ready to hear from you. Please unmute your
Hello.
mic. Please unmute your mic and start. Thank you.
Yeah. A 28 years old woman married since 6 years approached to fertility clinic for the secondary infertility for 4 years. She had 4 abortions in the past. She attended a health screening about a year ago and had an ultrasound pelvis done. Shows a septate uterus. She has a regular menstrual cycle associated with dysmenorrhea requiring regular simple analgesia but did not complain of dyspareunia. Hello? Yes.
Yeah, I can. Yeah, this is the imaging studies. You can see. Please go ahead. Please go ahead.
Yeah. Imaging studies through hysterosalpingogram, ultrasound, and magnetic resonance imaging, that is MRI, confirm the findings of septate uterus.
Yes. So please guide us now. What are you going to do?
Imaging. Yeah. Since we have clear diagnosis of septate uterus, I would like to go ahead with the hysteroscopic resection of the septate.
Yes.
With guided of along with hysteroscope, we would like to put a laparoscope as well to find out the other condition of this tube and uterus surface. And while performing the she underwent the uterine septum resection with a concomitant laparoscopic. Laparoscopic dye test was also done, and this showed patent fallopian tubes. And
I would stop you here, and please, if you can tell the viewers, how would you go ahead with the uterine septum resection? What will be the procedure? What will be the distension medium? How will you approach it? Will you use a cold knife or a scissor and cut the septum? And at the same time, you would like to do a laparoscopy. So please enumerate all these things. Thank you.
Yeah. First of all, since we have the diagnosis is already made, so I would like to put before the procedure, I would like to put a bisoprost insertion, so as the cervix will be easily dilated, and operative or resectoscope, which will be helpful to dilate the cervical canal and will be easier for the procedure to take place. And with the now constrict the size of the septum nowadays, 2 electrocoagulation diatherapy, the bipolar cautery, and the secondly Caesar also would like to. I prefer to use Caesar and do resection, and with a normal saline. Then do under vision, we like to cut the septum and check on the hemostasis, and the pressure should not be exceeding more than 200, so as to avoid the influx and avoid the pulmonary complications of hysteroscopic surgery. At the same time, I would like to monitor the inflow and outflow of the fluid which is to be considered at the time of the procedure, and the parameters for those vitals and SpO2 findings that has to be should be monitored during the procedure. And as soon as the procedure is being done, we would like to put a laparoscopic from the umbilical port, so as to check on any injury to the or any perforation that can be taken care of. Look for.
Yes, I agree. Absolutely wonderfully explained. Thank you so much. Please go ahead. you like to put an intrauterine contraceptive device, or would you like to put a pediatric Foley's catheter, or would you like to just leave it? Your comments on that.
I'll prefer to put a IUCD.
Okay.
Hello.
Yes. Yes.
Yeah. Then ask her to come for a follow up after 15 days or so and check on the threads again.
Yes. Yes. And what about giving her estrogen to encourage any endometrial regeneration? And when do you remove the IUCD and all those details? Can you please explain?
Yeah.
Thank you.
Hello. Yeah. Usually,
Yes.
after the next cycle, usually 15 days follow up. I remove the intrauterine contraceptive device and check on add on the Amigra tablet and see for the endometrial regeneration and take the follow up every month. Yeah.
Okay. What you would like to do XC for her or directly for IVF, or would you like to just give her some trial for
No.
IUI?
After the resection, would like to give in case of this. She doesn't have any problem of conception, so would like to give a try again. After resection, she can go for the natural cycle, 2 to 3 cycles, and then if not so IUI and followed by IVF, it can be advised if at all.
Thank you. Thank
She
you
doesn't
so
conceive.
much. I hope Dr. Kiran,
Okay.
Dr. Arun, you are completely fine and satisfied with the answers. Would you like to add something? And if that is fine, then I would like to go ahead with the next case. In case you would like to comment something, sir. And of course, the chairperson also can comment, please, for any of these cases. Yes. Thank you. So we go ahead with the next case now. And Dr. Mugdha Bamre, she's from Malegaon. Please go ahead and read your case. Thank you.
Hello everyone. Can you hear me?
Yes, madam.
My case today is a married female patient, aged about 31 years, attended a gynec OPD with a complaint of menstrual irregularity since 15 years, and she was. Oh, should I share my screen actually?
Madam, you can see the case.
Can I share?
Okay, I will stop sharing. Fine.
Yeah.
I stop sharing. Please share your screen.
Just a minute. I'm sorry.
In the meantime, I would like to tell you, Dr. Arun, your presentation was liked by many. There are many members who have thanked and congratulated your presentation. Dr. Sanjeev Shah, Dr. Shubha Gupta, and there are members. This is from Dr. Sumbul Fatima, Bangalore. Very informative and good explanation, sir. So it was wonderful, Dr. Arun, to see you presenting your case. And in the meantime, we will hear from Dr. Mugdha Bamre, who is from Malegaon. And we have more than 800 users who have been logged in and are seeing you live. And that's a wonderful way. Thank you. Is there any issue? Then I can share the screen with you, Dr. Mugdha Bamre.
Sir, I have a slide. I shared it previously. I'm just not.
It happens. It happens when we are in the COVID era time. We have certain glitches and itches, but there's nothing to worry. Your case is a very simple one, and it's regarding the patient having 4 abortions. If I may continue, and she's I think about 31 years of age. We had with her coming to us, and this is what she is showing. She had undergone a diagnostic hysterolaparoscopy. We performed it, and the uterine cavity length was just 3.5 centimeters, and was irregular with multiple adhesions inside. So you can see this, that there were dense adhesions, and that's what the features were suggestive of Asherman syndrome. The fundus bilateral ostial bicornu was not visualized properly due to the adhesions. Dr. Mugdha, can you see the slides? So how will you manage this case?
Now, please, now. Sir, can I share now? Now I'm able to share my case.
Yes, yes, yes. I'm stopping to share. You can share your slide, please. I love this. You're sharing, I sharing. You sharing, I sharing.
So
Yeah.
my case presentation today is Asherman syndrome,
You can
wherein
do the full screen, which is down here. Yes.
yes. So in the case,
Thank you so much.
my patient is a 31 years old female with a chief complaint of menstrual irregularities in 15 years, with a secondary infertility and married since 12 years. She has an obstetric history of 4 abortion, which were 2 months spontaneous abortion. Her diagnostic hysteroscopy revealed a cavity size of 3.5 with a multiple firm adhesions. Fundal and bilateral osteal cornua were not visualized on hysteroscopy. So now we will be hysteroscopically scoring this case according to the hysteroscopic scoring system. So now the dense adhesion with a multiple band is score as 4. Tubal ostia, both not visualized, is also score as 4. Tubal cavity, which is less than 6, is score as 10. And symptom of recurrent pregnancy loss is score as 2. So our final score is 20. So according to this scoring system, our patient falls into a severe category, severe case of Asherman syndrome. So how do we manage this case? For the basic of understanding, I have divided the management of this case into 4 steps. First step is the management of the surgical procedure, where the primary aim is to restore the normal size and the shape of the uterine cavity. And secondary aim is to relieve the associated symptoms. Second step is to prevent the readhesion formation. Third step is to restore the normal endometrial development. And fourth step is to assist the patient post-operatively. So we'll go stepwise. First step is the hysteroscopic anesthesiolysis. So in this, it is a gold standard technique where there is a magnification and direct view of the adhesion. Hence, it is a very precise and a safe procedure. How do we approach for the adhesiolysis? Basic rule is that always concentrate on the central and flimsy adhesion first, so as there is an adequate distension of the uterine cavity, so we can address the dense and lateral adhesions at the end of the procedure. Now, the uterine cavity mapping is essential, which can be done by USG, HSG, or by CARM guide technique. In our case, already a diagnostic hysteroscopy was done. So how do we prepare the case of a severe Asherman syndrome? We start the patient with on an estrogen validate from 8 to 16 milligram per day, 2 weeks prior to the surgery. On admission, we generally put a misoprost 200 microgram tablet per vaginally 4 hours prior to the surgery. Because this is a severe case, we are using a type of anesthesia that is used as a general anesthesia. In case of a mild Asherman syndrome, sometime of office hysteroscopy with a local anesthesia can also be used. So what are the different types of adhesiolysis? What are the different methods from which we can do adhesiolysis? For most common and most ideal method is scissors, where we are using mechanical cuts to separate the adhesions. The most unpopular one is the laser, and others are monopolar hooks or bipolar electrodes. So now we'll take mechanical and electrical equipments chronologically. Scissors as entitled to the mechanical cutting have a very minimal damage to the endometrium. Hence, an intrauterine scarring and fibrosis after post-surgery is very less. So the removal of the scars and adhesion by a non-heat generating scissor, which is also known as cold knife approach, is the best and the ideal approach. Perforation with this method is very less. If at all happened, bleeding is also very less because the diameter of the scissor is very small. The learning curve of this procedure is shorter and it is easily reproducible. Hence, it can be mastered easily. Second option with an electrical equipment is an Versa point system, which uses a bipolar electrode, where an distension media is an isotonic media, and the principle of action is hemostatic vaporization and hemostatic resection. the extent of a damage as compared to the monopolar is much lesser with the Versa point system. The only disadvantage is that it is extremely expensive. Third point is the monopolar resectoscope or a monopolar hook, where the distension media, as we all know, is a glycine, which is a hypotonic non-conductive material. As it is a non-conductive material, there are no electrodes present in the conductive material. Hence, the chances of fluid overload with a hyponatremia is very high, which is the main complication with the procedure. What is the principle it works with? It works with cut and coag by contact coagulation. The pure cutting current of 90 to 100 watts is used in this procedure. Very less known and very unpopular one is the laser technique, among which the ND yarn is the most popular one. The penetration of the laser is 5 to 6 mm. There are two techniques by which the laser acts. It's by the dragging or the blanching. The constant motion is very essential in the laser ablation technique because the risk of perforation is very high. Hence, the distension media that we use is normal saline or dextran 17. Now we'll go to the second step, which is re-adhesion prevention. So how do we prevent those adhesion which can be again formed? The most common and one of the first mechanically used device is the Foley's catheter. In this, we use a Foley's catheter number 8 or 10, which is a pediatric Foley's catheter. It is distended up to 2 to 3 ml, mostly 3 ml, not more than that. It is kept in the cavity for 7 to 10 days. The biggest concern with this prevention is the ascending infection. So we have to back up with an antibiotic. Moreover, discomfort is another point which patient is concerned about. After Foley's catheter, which is the most popular one, is the IUCD. IUCD is physiological endometrial regression by separation. IUCD acts by physiological endometrial regression by separating the anterior and the posterior wall of the uterus. Which is the most commonly used IUCD is the copper device. There are some studies which says that the copper may have an aggravated endometrial injury, but most of the times within 3 weeks, there is a good endometrial thickness that can be achieved. Levonorgestrel releasing IUCD has a suppression effect on the endometrium, hence it has to be backed up with estrogen if at all used. T-shape IUCD is too tiny to form any mechanical barrier, hence not used. Lipase loop being an adequate device is no longer available in the market. The intrauterine balloon stent, which is also called as, which is also called as Cook's balloon, is a mechanical method again like a Foley's catheter to prevent the adhesion. It is made of a silicone which is a triangular in shape. The pregnancy rates are very high, which is 61%. Again, it has the same disadvantage of an ascending infection. Hence, a prophylactic antibiotic has to be given. Other anti-adhesion barriers such as gel barrier, such as hyaluronic acid and spray gels and Cepra films are also been there in the studies, but currently they are not available in the Indian market. Now, how do we restore the normal endometrium? There are two. First is the medical therapy, where we use the hormone therapy. Hormone therapy encourages the fast growth of the endometrium immediately after the surgery. What is the purpose? They are dual purpose. It prevents the scar formation and it restores the normal uterine environment. How do we achieve it? For achieving it, we have to have a supra-physiological hormone levels. In the mild cases, we can have an estrogen value rate 8 to 6 milligram per day for 25 days, followed by medroxyproline mg for 5 days for 2 to 3 days. In severe cases, we can give estrogen as a continuous therapy without any break for 2 to 3 months. Another medical therapy which we can use is the sildenafil citrate, where the endometrial blood flow and the endometrial thickness can be increased because of the use of sildenafil citrate, being a vasodilator. Certain studies of stem cells as endometrial tissue contains an epithelial progenitor cells and mesenchymal cells have been showing of a new generation of the basal endometrium. Granulosa GCSF has also been used, which is a granulosa cell stimulating factor, which has been used in the concurrent failure of implantation cases. Plasma-rich, platelet-rich plasma, as we all know, has been tried and tested in a lot of regeneration therapies. In the same way, it has been tried and tested in the normal endometrial growth studies. Now, the fourth stage is the post-operative assessment. It is the most important stage because the complete resolution in severe cases, most importantly, is not always possible. Hence, there is a high recurrence rate, and a timely recognition of this recurrence is important to provide a best prognosis. If not done, there can be an increase in the obstetric risk. Resuming and restoring of the menses is one of the best markers to see post-operative assessment. It is recommended to do a post-operative assessment, if at all, as an intervention after 2 to 3 months of the first hysteroscopical procedure. Which are the different methods that can be used? First is the ultrasound, which is accurate and cost effective. Second is the HSG, where a tubal patency can also be checked along with the accuracy, along with the endometrial thickness. And third is the most accurate and most commonly used, which is the hysteroscopy, as we can tackle the reformed adhesion and cause the adenolysis again, for a better prognosis. Thank you.
Wonderful. It was a lecture of Asherman syndrome, and you enlightened us, all of us. You have covered all the topics. We will get back to you. I request you to please stop sharing, and I will go ahead with my sharing.
Yes.
We will get to you the questions because Dr. Narwadkar sir is waiting for us, and his presentation is going to be starting soon. So, where is my presentation? 1 minute. Yes. So,
Thank you, Dr. Niranjan, for including me in this panel. And because of this, I have read the things which I have almost read after 20 years. So it is rather beneficial for me rather than more than delegates.
yes, please. I hope you can. Thank you so much for joining from Nanded. It was a pleasure to have you. You're representing Nanded Society. Please go ahead and read. Thank you.
The 35-year-old lady with a repeated second trimester losses or a preterm births. There is a history of a painless cervical dilatation and the labor was precipitated. And if the cervical length was less than 15 millimeter, and when this case is being followed up, there was a cervical length reduction by 1 millimeter a week. And clinically also the cervix is very short when the examination was done. Now, there is a change in the terminology. The cervical incompetence, now they say it's a cervical insufficiency, that there is a difference in term. And the insufficiency where there are no contractions, no labor, and yet the patient has progressed and aborted, or there was a preterm delivery. This is being, there is a how do you do a diagnosis? There are 2 or 3 ways. Like if there is a history of a second trimester losses, 2 or 3, then the diagnosis is clear-cut evident. Or you can follow the patient in a second trimester and there is a shortening of a cervix on ultrasound, or a clinically based, like you are examined and you found the cervix is shorter, then you can say that it is a case of a cervical incompetence. Now, in this given case, the cervical length is less than 15 and there was a previous history of mid-trimester losses, then she's a clearly case for a cervical circlage. If there is a history of a second trimester losses, you have to give a circlage. If you find the cervix is shortening on a clinical examination, but there was no prior history, this patient can be managed like either with a progesterone or either with a cervical circlage. And even if you find that the cervical length is less than 25 or less than equal to or less than a 25 millimeter, then the indication is to given a circlage is necessary. And even in the clinical examination, if you find there is a cervical shortening and the length is less than again a 2 centimeter, then the circlage is necessary. You can do either vaginal circlage or it's a transabdominal circlage. Generally, the transabdominal circlage is restricted to very few cases because it's a very morbid procedure. and it requires a higher expertise, sometimes laparoscopic skills also. But the commonest procedure done is McDonald cerclage, and the second one is Shirodkar cerclage. Shirodkar is again, it's a highly demanding surgery because there is a dissection at the level of the bladder and the rectum. Generally, it is to be given after 12 weeks, but not certainly beyond 24 weeks. There are certain patients have been given after almost around 28 weeks also, but not before 12 weeks, because at that moment the abortions related to aneuploidies happens to occur. So it should not be very premature, or it should not be delayed also. And one thing I learned while going through this is there are indication to give a tocolysis around cerclage is I have gone through this. They have used indomethacin, which is very interesting. I have read it, but it is very genuine to use indomethacin for 48 hours. My first dose is around 50 to 100 milligrams, then 25 milligrams every 6 hours, not more than 72 hours. Or there are we are using Duvalina, like isoxsuprine and nifedipine and terbutaline also. But and as it has been suggested that there are certain things we do without any literature evidence. Like if you see that progesterone, which shows that only 33% of the patients do benefit from the use of a progesterone in prevention of second trimester losses or a preterm labor. But if you see the prescription of each and every patient, you can see either 2 or 3 progesterone being added simultaneously. But if there is a history of preterm labor and you are given a cerclage, then probability and you find a cervical shortening and given a stitch, then use of injectable hydroxyprogesterone is indicated. And there was no history, but you are finding a cervical shortening, then you are either in a dilemma whether to give a stitch. Then in that scenario, the literature is in favor of using a vaginal progesterone till 36 weeks of it. And they say that you should start it after 16 or 18 weeks of a gestation, not prior to that. Why progesterone? Basically, if you see that the RU486, it's a progesterone receptor antagonist, or if you happens to remove a corpus luteum, then the pregnancy will abort. That is the reason that why you should use a progesterone. And the mechanism is not very clear how the progesterone brings about an uterine quiescence, but it is maybe an immunomodulatory efforts has been is in favor of a progesterone. And it has to be, and once you see that once you are given a transvaginal and patient has ultimately aborted, or there is a PRM, or there is the pregnancy has not gone to a successful tenure, then you might consider transabdominal. There are certain indications. When the cervix, now in this case, the 1.5% or 1.5 centimeter is very difficult to take the stitch from the vaginal angle. So sometimes we like to go to the transabdominal, a short cervix or a scarred cervix, or the cervix is not seen very properly. In that scenario, you can go with a transabdominal or a transabdominal. Either it's an open laparotomy or a laparoscopic scale. Laparoscopy is less morbid compared to the open surgery, but it requires a highly skilled procedure. So it is always beneficial to do. But only problem that once you've given a stitch, then the probability that this patient needs an open a cesarean section, or sometimes there is a second or a first trimester loss, you can still do evacuation with keeping that stitch in situ. But a second trimester or a advanced pregnancy, you will have to do hysterectomy. And people have kept the stitch for a further pregnancies also, but the data is very limited. Dr. Niranjan.
Yes, you have done wonderfully the explanation given by for cervical incompetence, how to approach the case and how to do when to do the stitch, when to take it, when not to take it, and what are the interventions like progesterone, like HCG. And we are at the end of the panel, and this is how we can see that the evaluation and the management, the factors are on the left hand side and the therapy is on the right hand side. In between are the diagnostic evaluations and the abnormal results which you can find in immunological situation, parental structural, chromosomal rearrangements, Well, when we have an endocrinological issue, you have to do all those evaluations which are been mentioned here, and the therapy. These are the drugs which can be given when there is an anatomic defect. That also we have covered. The role of hysteroscopy is a very big one. HSG, sonosalpingography or sonohistography is going to be very essential, and you need to do adhesiolisis or a myomectomy or a hysteroscopic metroplasty to solve this issue of RPL. There is coagulation defect issues also, and I would like to stress here that yes, there has been evidence that there could be abnormalities detected up to 8 to 12%, and it could be related to factor V, Leiden, or prothrombin gene. It could be something related to homocysteine, protein C activity, protein S activity, and low molecular weight or fractionated heparin and folic acid is going to be very helpful in this thrombophilic patients. If there is any microbiologic issue, we can give antibiotics for any infections, and maybe you will have to do an endometrial biopsy, cervical or vaginal cultures. Well, patients also have psychological issues in such conditions. They require mental status evaluation, psychological counseling. You have to have a support group, and not necessarily absolute medications, but if required, you may have to take an opinion of a psychiatrist. And of course, there are certain factors which we do not have an answer, for which they have repeated abortions. It could be related to excessive exposure of toxins or smoking, tobacco, alcohol, caffeine, etc. And there you have the studies to be done. So with this, I would like to thank all of you for being with me. And there are many questions which are there, and we will take one by one. This is a wonderful presentation. Dr. Alpana Agarwal from Bareilly says it is wonderful. There are many remarks to be given to all of you. Dr. Ashok Mumbai, he is from Railway Hospital. I remember Dr. Ashok Kumar. Superb lecture, very informative, and it is a great thing. Thank you so much for imparting knowledge. There is Dr. Uma Modgi from Nashik. Very informative presentations by each one of you, and an informative talk by Dr. Surekha Taide. I hope Dr. Surekha Taide is listening to us, and I would like to go back to her for some few questions. If she is there online, I would appreciate her to come online. This is by Dr. A. Padma. Does vesicular mole, missed abortion, blighted ovum, ectopic pregnancy less than 5 weeks, do they need anti-D prophylaxis? Dr. Surekha Taide, your take on this. If you're online, please come on live. Well, I think Dr. Surekha Taide is busy, probably cooking some meal or something. And then we have so many experts who can surely answer on her behalf. So I would like Dr. Shekhar Amale to take this question. Do you require anti-D prophylaxis in such situations of missed abortion, ectopic pregnancy, or a blighted ovum? I think Dilip Bambre sir, you had also asked the same question regarding the culture in such situations, and I want to go ahead and ask the next same question related to that to Dr. Shekhar.
Sir, in this case, what you want to ask is that whether there is exchange of blood, means blood is maternal blood is whether it is transfer into the fetus, and there is an exchange of the blood in between two. That is the thing. But this is the question which nobody can answer at present. 5 weeks, if it is the amniotic sac also, the chorionic villi are getting formed at 5 or 6 weeks in early stage also may have changes. Giving one anti-D is no harm. That's why, according to me, anti-D should be given in such cases.
Yes. I think it's a very gray area, and I appreciate your suggestion. There's one more question. This is by Dr. Varsha Ghal. What about MTP pills? You give an MTP pill to a Rh negative patient. Is it mandatory to give a half dose anti-D injection? Any one of you?
Yes, of course. Any case, whether MTP pill, so mode of abortion.
Come on live. Oh, thank you. Yes. You are our savior. Please.
Dr. Niranjan, this is a very good question actually. The mode of abortion actually does not have any say. So whether it is an empty pill or a surgical termination or a spontaneous abortion does not matter at all. So if it is a termination of pregnancy, we need to give the immunoglobulin.
Okay, okay. I will just take one or two more questions. How do you calculate the dose of anti-D to Rh negative mothers after delivery, depending upon amount of feto-maternal hemorrhage? This is Dr. Niranjan Nayak. He is a combination of Niranjan Chavan and Arun Nayak. I am surprised.
So this I have very nicely.
Translocation.
So I have already talked about this in my slides. We do the Rosette test to find out if there is a feto-maternal hemorrhage. After that, we need to do the Kleehor-Betke test, the acid elution test. This will tell us about the amount of bleeding, and depending on the amount of bleeding, we calculate the dose at the by knowing the gestational age. So gestational age minus 20 into 10 will give us the dose, and then we calculate depending on that. We calculate so 20 microgram per ml of feto-maternal hemorrhage. That is how we go about doing our dosing. So 300 microgram may not be enough if there is a large amount of feto-maternal hemorrhage. In a normal delivery, we consider only 0.5 ml of feto-maternal hemorrhage. So if more feto-maternal hemorrhage is there, the dose will be more.
Niranjan, can I just make a comment here?
Yes, 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 Dr. Arun, please.
Okay. You will recollect when we were students, there was a procedure called menstrual regulation. We used to do it using menstrual regulation syringe, and it was like when pregnancy is not confirmed and it is for regularization of the menses. So that was the idea of doing menstrual regulation. And if you recollect, one of the advantages of menstrual regulation that was mentioned was because the pregnancy is early pregnancy and the RBCs have not formed, so there is no need of giving anti-D. It was quoted in our textbooks that anti-D globulin need not be given after doing the menstrual regulation. But I think the days have changed, and nowadays I don't think even after a menstrual regulation or early pregnancy, missed abortion, blighted ovum, whatever may be the case, we should give the benefit of anti-D globulin to the woman, and we should not we should not end up in a situation of not giving anti-D, and that is why the patient has developed the isoimmunization. So, irrespective of whether it is early pregnancy, blighted ovum, ectopic pregnancy, at least that minimal dose of 50 to 100 microgram should be given to each and every patient who is RH negative.
I agree, Dr. Nayak here. Yes. Even if it is, we are just wanting to give a 50 microgram dose. Yes, so even if it is menstrual regulation and anything, pregnancy test was positive. She is a pregnant woman. It is a termination. So so whether early or late doesn't matter. Yes, we have to give the benefit of the immunoglobulin to this patient, so that the subsequent pregnancy doesn't have a poorer outcome, because we did not give this simple preventive dose.
Yes, absolutely. I totally agree. The days have changed. Nowadays, nobody does menstrual regulation, so we should not think about not giving anti-D globulin at all.
Wonderful explanation, Dr. Arun Nayak, sir, and Dr. Sureka Taide.
And we were doing the MRC range and all, but now they are. Yes, but people consider that only if you do a surgical termination, we should give the RH immunoglobulin, but that is not so. Even for medical termination, we should go ahead and give the prophylactic dose.
Yes, yes. Dr. Varsha wants to say something. Please add.
When it is called as a prophylactic dose, it has to be considered of abortion or empty pill. We have to consider non-maternal, feto-maternal hemorrhage, which gives anti-D at
Dr. Varsha, your voice is cracking. Number two, you have to come near the mic. You have to come near the phone. And please, it is muffled sound. So please be loud and clear. Yes, please go ahead.
Hemorrhage is given a prophylactic dose at 28 weeks. No. Am I audible?
No.
No.
Can't help it.
No. You are not audible. I think there is some issue regarding the connectivity.
You can type it down.
Yes, and
You
we
can
will
type
answer
it
and we
down.
will get back to you. I love that Dr. Shekhar Amle, very good advice been given. And it's like a day and night match I'm having today, but there are no teams. And I'm very happy to see all of you from various parts of the country. And I come back to Dr. Sureka Taide. We are not going to leave you soon. I can find two Sureka Taides here, but I'm going to talk to only
Sorry.
one. I'm going to talk to only one person. And at 28 weeks, G2P1L1 with ICT positive, no other findings how to manage. This is Dr. Nilima Ganvir.
What she's saying, RCT?
ICT positive.
ICT.
ICT
28
positive,
weeks
second
of
gravida at
gestation,
28
we
weeks.
consider, yes, so we consider depending on the titers. So we consider, because see, there are two types of monitoring we can do for this patient. She is a sensitized woman, so isommunization, she is sensitized. So what we go about nowadays, we recommend is that we do the Doppler of this patient. So we do the MCA Doppler of this patient and find out the peak systolic velocity. Now I have already told you what we consider as a so if the peak systolic velocity is above 1.5 mom, we consider that is the affected fetus. So moderately affected fetus is 1.5 mom. If it is less, it is higher than 1.5, then we consider 1 minute.
Yes.
Okay. So we consider that we have to go ahead, and if it is severely affected fetus, then we have to decide whether the intrauterine transfusion has to be given to this patient. So that is how you decide. If it is poorly not affected, then we keep on doing the MCA or Doppler of this patient every 1 to 2 weeks.
Okay, one more question to you. This is there any role of anti-D for Rh negative woman with Rh positive baby after she has been tubectomized? Dr. M. Vijayashri.
See, even if she has been tubectomized, we cannot say. Many a times, if you want to, even if she is tubectomized, we should go ahead and give the prophylactic dose. Why? Because if she wants to do the reversal of tubectomy later on in life, if she has a second marriage, what do we know? So in that case, we should still go ahead and give this anti-D to this patient.
Okay. Okay, fine. There are still many questions which are coming, but I think due to shortage of time, we will have to end the scenario of this webinar. And Dr. Varsha Lade just typed, and I want to read that thing, what she has typed. The feto-maternal hemorrhage mainly during placental invasion is happening, unknown, so prophylaxis is given. That's what Dr. Varsha Lade had to say. This is Dr. Chanchal Garg. Last question I am taking. Morena, in the case of missed abortion, if the patient comes with bleeding, what is the dose? I think we have answered you this question. And with this, I would like to end the webinar. I would like to thank the AMOG's office bearers, Dr. Kiran Kortakoti, Dr. Arun Naik sir to be with us, and all the esteemed chairpersons who are present with me today, Varsha Lade madam and Dr. Dilip Bambre sir, and of course all the great panelists who have presented their cases. I would like to name each one of you, Dr. Arun Naik, Dr. Mangesh Narwadkar, and Dr. There is Dr. Shekhar Amle, and we have with us also the guest of honor today, Dr. Arun Naik and Kiran Kurtakoti. with this, I would like to end and thank you. It was an interactive session with all of you, and it's a pleasure to be joining you soon. And we will get back to you. Thank you so much. Thank you.
Thank you so
Thank you.
much, Dr.
Thank you.
Niranjan, for inviting me. Thank you.
Thank you.
Thank you, all of you. Thank you, Arun. Thank you.
Thank you,
Thank you.
doctor.
Thanks.
Thank you, Dilip. Yes.